Hello everyone. My talk today will be about dealing with children in strabismus. Evaluation of strabismus requires a long list starting from a good history taking and going all the way down to reaching a correct diagnosis and putting a correct decision plan. The question is how can we achieve this in children? The two main problems are that children might not allow you to get this information. In addition, for younger ophthalmologists, it might not be possible to get this information. Why is examination of children difficult? There are many reasons for this. There are problems related to children, the stigma related to being a doctor, the atmosphere of the examination, and the acquaintance of the examination technique. Infants and toddlers are nonverbal. They don't understand what you want, and they may not do what you want them to do. Children don't like doctors. To children, doctors are the creatures that parents threaten the kids with. So you are the demon or the monsters in their parents' story. So please, when examining children, do not start by touching the child. You can gain confidence of the child by talking to the parents first for a while to start changing the picture in the mind of the kids. During examination, do the fun parts first. Test the eye movement with toys or sweets, and do the sensory tests and the games first. Delay the cover test and testing fixation because they require some touching of the child, which children don't like. Because children don't like the eye drops, remember to delay the eye drops and the fundus examination until the end of your evaluation. So what do you do if you can't get enough information? You can send the child back home and see him once more at another time. Remember, if you don't have time for the child, he doesn't have time for you. Let the parents help you at home. Parents can teach and train their kids the e-game so that the next time you can test the visual acuity more efficiently. And you can also print the photos in your chart projector on a piece of paper and ask the parents to teach them to their kids before examination. You can also let the parents put the eye drops at home so that the child does not correlate between you and being getting hurt. And if the parents are well educated, you can ask them to tell the child what kind of game is he going to play in the clinic. However, sometimes you may fail. In such cases, you resort to asking the parents to holding the child by force. This is best done by keeping the legs of the child in between the legs of the parents and holding his hands behind his head. Another factor that influences the examination is the atmosphere of examination. Most of the examination in our public hospitals are held in crowded areas with poor aeration. Children and their parents have been traveling for long distances and staying for a very long time in queues until they are finally able to reach you. It's quite hard to expect the children to be cooperative in such situations. Children can easily get distracted, especially when there are plenty of other people in the room, especially when combined with a number of crying kids. So it would be quite hard to expect the child to sit peacefully on the slit lamp or autorefractometer to get examined. So remember to create a pleasant atmosphere for the kids. In some cases, you might ask the patient to come back and examine him at the end of the clinic or in the inpatients department to have him examined in a less crowded environment. At the beginning of your career, you might need a longer time to elicit signs and to finish your examination. However, Signs can be seen in children only once during examination. So try to examine a lot of adults to understand what are you expecting to see in children. You need to have different tools for examination. The tools are needed for testing fixation, for motility examination, for testing visual acuity, for refraction, and for decision making. Remember that you need a variety of fixation targets for children to capture their attention. Remember that the infant who thinks that your bent torch deserves looking at is quite rare. So try to capture their attention. You can have a variety of tools to capture their attention, mainly toys and sweets. Remember that the rule says one toy equal one look, so you need a plenty of weapons. Motility can be tested by different methods. This can be done by simply asking the patient to look in different directions while stabilizing his or her head. Or you can use a fixation target or a toy for the patient to look at or to follow. In some children, you can use something with a sound to attract their attention and for the child to follow. In younger or uncooperative children, you can use the doll head maneuver to test the motility. You simply move the head in the direction opposite to the gaze being tested while maintaining the fixation target in place. The vestibular system will simply move the eyes opposite to the direction where the head moved. So in order to differentiate cross-fixation from a true limitation of abduction, you have to test deductions to see if the limited abduction will persist. This is best done in young children by covering one eye and testing deduction using a dull head maneuver. You can see that the eye starts to abduct better, indicating that there is no true limitation of abduction, but only a cross-fixation mimicking limited abduction. Visual acuity in children is tested differently than in adults. You need to test the visual behavior of the infant. A good fixing infant responds to a silent smile. He should follow objects around the environment. Pupillary reflexes, if present, indicate an intact afferent visual pathway back to the superior colliculus and an efferent pathway down to the iris sphincter. It normally appears at 30 weeks gestational age, but may require a magnifying glass to detect because pupil is small and the amplitude of the light reflex is small. The blinking to a bright light reflex is a behavior learned by the 30th week of gestational age. However, you should avoid blushing air to the cornea, which might cause a false blinking reflex. Occlusion of one eye, if strongly objected by a child, indicates a poor visual acuity of the uncovered eye. The fix and follow test is another way to test the fixation behavior of a child. You can also do the central steady maintained method. You cover one eye, the light reflex should be central and steady. Then take off the cover, the fixation should be maintained even with both eyes are uncovered. A poor CSM indicates a poor visual acuity. The 100 and 1000 sweet test is another way to test the visual acuity. If the child is able to pick small sweets at 33 centimeters, then the visual acuity is over 624. The preferential looking is based on the principle that infants prefer to fixate pattern rather than homogeneous stimuli. This can be done using either the Teller Acuity card or the Cardiff Acuity cards. Finally, you can use the optokinetic nystagmus to test the visual acuity of a child by presenting a series of moving targets of gradually increasing frequency. When the frequency exceeds the resolving frequency of the eye, the optokinetic nystagmus stops. In verbal children, testing visual acuity is a bit easier. This can be done using a picture naming test, such as the K single picture or the multiple picture test, or using a matching letter optotype test, such as the HOTV test. As the child gets older, you can use the same test used in adults, such as the Landolt and the Snellen charts. Now we finished dealing with children. You now have to deal with their parents.